This conference will now be recorded.
Good afternoon, everyone, and welcome. This is Tracy Morton at the National Rural Health Resource Center, and welcome to today's TASC 90 webinar. For some of you joining, this might be your very first time on a TASC 90 webinar, and so I just wanted to explain a little bit about the purpose of these webinars. These webinars are held quarterly, and they're directed to the State Flex Program personnel, so State Flex directors, State Flex coordinators, and other people working on the Flex program within the state offices that are the designated entities for the Flex program. And it's really meant to be a topical update on something that might be pressing at the time or an area of need or of greater interest within the Flex community and the critical access hospitals that we're serving within the Flex program. The webinars are called TASC 90 because they're 90 minutes long. And so look for these to continue to happen on a quarterly basis. They did happen prior to this, so two of them in the last program year were kind of gobbled up by the long webinar series that we did. So we didn't have the standard TASC 90 webinars as we normally did. So I just wanted to take a second to point that out. I'll go over the agenda today, and then we'll dive into some of the program updates. We'll start with an update from the Technical Assistance and Services Center, or TASC, followed by an update from the Federal Office of Rural Health Policy and the Critical Access Hospital Regulatory Update by Christy Martinson and Aaron Fishbach. John Gale will be joining us from the Maine Rural Health Research Center at the University of Southern Maine, which is a member of the Flex Monitoring Team, to provide an update about the work the Flex Monitoring Team is currently doing. And then we'll dive into our topic today, which is about Quality Innovation Networks, an introduction to the new Quality Improvement Organization model. And we'll be joined by two speakers, Kim McCoy with Stratus Health and Gayla Middlesteed from TMF Quality Innovation Network. And then hopefully at the end of the call today, we'll have a little bit of time to answer questions or dive into a discussion about the Quality Innovation Networks and how they can integrate and work well with the Flex program. So just a few short updates here from TASC. We will be reaching out to the states and asking you each to complete your state Flex profile update. If you go onto the TASC website, which is ruralcenter.org/TASC, T-A-S-C, you'll see on there on the right side green menu, there's something that says State Contact Information and State Flex Profiles. And in there are the profiles that each state completed last year. Annually, we update that content, not only with contact information, but also content about the work that you're doing within each of the core areas, your areas of success, and network activities, and other things about the scope of your program, the number of FTE you have, where your program might be housed, how many critical access hospitals you're serving. So we'll be sending out an email to you shortly asking you to update that profile, and we'll be looking for those updates to happen by the end of this calendar year. If you haven't yet taken the opportunity to look at the new webpage that was updated for the MBQIP site, I encourage you to do that. So MBQIP, again, is the Medicare Beneficiary Quality Improvement Project. And the website has been reformatted to group the resources and information available by healthcare category. For example, it's grouped by inpatient, outpatient, patient satisfaction, patient safety. So there are dozens and dozens of new resources that have been added, including evidence-based best practices that have been identified with the Agency for Healthcare Research and Quality, or AHRQ, that align with the various MBQIP measures. And there's also an excellent MBQIP frequently asked questions section, so take a look at that. The content on the website will continue to be updated, and you can access the new webpage at www.ruralcenter.org/TASC, T-A-S-C, /MBQIP, MBQIP. If you see something missing, please let us know, and also we'll continue to engage in the discussion and share resources about MBQIP within the Flex program forum as well. Also about MBQIP, we'll be creating a best practice guide. So this fall and winter, we'll be working on developing an MBQIP best practice guide to assist state Flex grantees and critical access hospitals participating in MBQIP to shift from reporting of data to actual quality improvement action. The guide is going to focus on interpreting MBQIP data, identifying gaps in quality of care, defining evidence-based quality improvement activities, and establishing processes for future benchmarking to continue improving quality of care in the critical access hospitals. The guide will be disseminated to the critical access hospitals through the state Flex program, programs, and it will be posted then, of course, to the TASC website too. So more information to come as that continues to be developed, but just wanted to let you all know that that's coming. Yesterday, an email was sent out to the Critical Access Hospital administrators email list notifying them as a reminder that they should have received the Critical Access Hospital Financial Indicator Report for this year. They receive a mailed letter that provides them with login information to access their individual unique financial indicator report for their Critical Access Hospital. The state flex programs have access then to the reports for all the CHs within their state. So we ask you to please remind your CHs to access those really valuable reports and to contact either the flex monitoring team or TASC if you have any questions, and we can be of assistance. They're an excellent, valuable resource and information also that should be incorporated into your needs assessment that you're working on the next grant cycle. There's another great project that we have coming on in the hopper about a population health toolkit for critical access hospitals, and Terry Hill is going to tell you a little bit more about that.
Right, and again, with the Affordable Care Act and the development of accountable care organizations, the Medicare program, many states moving into ACO-like arrangements in places like Oregon, and Minnesota has a number of those as well. We're seeing more and more critical access hospitals moving kind of into these value-based models. Last month, we had the announcement of $114 million available for forgivable loans for rural ACO development. We're anticipating that there will be a number of critical access hospitals in your states that may be interested, if not moving into accountable care organizations, at least very interested in what is population health, kind of how can we prepare, et cetera. Kind of in that regard, TASC is going to convene a key informant group in 2015 that will help us put together a toolkit for critical access hospitals. It would be resources, obviously, that would be a benefit to our state Medicare Flex programs, but again, something that you can use to give out to these hospitals, and will be the kind of the best thinking of this group that we're going to be convening in the near future. So hopefully that's going to be very helpful. I'm excited about the project because it's inevitable that more and more critical access hospitals are going to be pulled into one type of arrangement or another, and so we're looking forward to the project and the production of the toolkit.
Thanks, Terry. And with that, I'd like to turn things over to Christy Martinson from the Federal Office of Rural Health Policy to provide the update from there and the CH regulatory update as well. Christy?
Thanks, Tracy. So I know you all are probably sick of hearing me at this point since we've had so many conversations over the past few months around Flex and the upcoming FY15 guidance. So with the call that we have tomorrow, I'm not going to talk a lot today about Flex. We have the call at 2 p.m. tomorrow, and I'll be sending out additional information for that call this afternoon. And since I had to cancel last week, we'll be covering both the financial and operational core area and then the community health systems development component of core area 3. And if we need to add time after the call tomorrow, since we just have an hour, if we do need to have time, then I'll schedule another call as well. But I do have exciting news today. I am happy to introduce Kevin Cheney, who just started last week. He's our new Flex coordinator, and then he'll be working with Region C with some grantees in that region as a project officer. So he's jumping right in. We're going to have a kind of slow transition just to make sure he gets up to speed because there's so much changing and so much conversations going on right now with the FY15 guidance. But he's ready to come in, get to know all of you, and get to know the programs as well. So I'll let him just say a little bit about himself, and then you'll get to know him as you continue to work with him over the next few months.
Thanks, Christy. Hi, everyone. Again, my name's Kevin Cheney. I'm, about a week and a half in, and as they warned me, and I knew coming in, the fire hose would be going full blast, in which it is, but I've actually really enjoyed coming and learning about the programs that I'm going to be working with, and I'm really looking forward to getting out and meeting the different folks across the area and learning more about what you're doing and hopefully how I can bring in a bit of my experience. Before I came here, I was over at the Agency for Healthcare Research and Quality for the past almost 5 years working on a variety of projects. Really, a lot of it was related to health IT, but I made a lot of really great connections over there. I think with different programs that I'm hoping to connect as it relates to the FLEX program here. My background is I'm got my master's in gerontology, which for those who don't know, it's the study of aging, and I've clearly, you know, if you keep looking back, I've had a unique route to get to where I am today, but I think it's very fitting based on my upbringing. I'm from rural Ohio, and so this position and the opportunity, I think, really spoke to me. As we move along, you'll get to know more about me. And again, I look forward to working with everyone. Thanks.
Thanks, Kevin. So I'll be sending out an email today with our updated regional liaison map, and that'll have Kevin's contact information in there as well. So that's just the FLEX update today, and now I'll turn it over to Aaron Fishbach, who will get into some of the policy issues from the federal office.
Good afternoon, good morning to a couple of you probably if you're on. Great to be on the call with you. I see that the regulatory update slides are uploaded, and if you're not able to follow along online, then just page along with us. I'll go to the second slide. So what we did is just giving you some updates on a few items of interest that have happened in the last month, month and a half or so. The physician fee schedule is on display at the Federal Register display version, and it'll be published supposedly tomorrow. But the 2015 physician fee schedule payments that take effect obviously on January 1st. I won't go into in-depth on all of these, but wanted to give you sort of a bulleted list, and then if you have any questions about some of them, you can follow up with me. A couple of the big ones that folks are usually interested in does expand some telehealth services. There's some new services there that they've gone into. It does eliminate an employment requirement for RHCs and FQHCs. The incident to services means all of those folks who aren't actually practitioners and who bill incidents. So nurses, allied health, all those people. Basically, the only person who has to be employed anymore as a formal W-2 form is one NP or one or PA at the rural health clinic or FQHC. The rest of the staff could be contracted. I did want to pop back up to the top. CMS did finalize the chronic care management services. Rather than what they've established is that there was a CPT code adopted by the American Medical Association, and so they're going to use that CPT code. The value is about $40 a month. One practitioner can bill it every month, and it has to be at the agreement of the beneficiary because there is the 20% co-insurance related to that. I put RHCs and FQHCs on there and crossed them out to make the point that they are not able to bill this code. These are non-face-to-face care coordination, care management types of services, and RHCs and FQHCs are required to have a face-to-face visit to bill and encounter. CMS is going to be looking at this over the course of the next year to see if there's a way to allow RHCs and FQHCs to participate. Note that for hospital folks and for others, that fourth bullet, they're under the physician fee schedule, and they paired it under the outpatient PPS rule, which is going to be next. But they're going to begin requiring reporting of hospital-owned physician practices. And that is, as we've seen reported, hospitals have been buying a lot of physician practices around the country. By most estimates, more than half of them are owned by hospitals now. And as a result, that usually results in a higher payment coming from Medicare for those services. And so they're trying to get a handle on what's happening there and how much of an impact that is having on Medicare. And as an aside, the Office of the Inspector General, for its 2015 work plan, is also going to be looking at this issue. So there's going to be more attention brought to this. They're implementing the value modifier. It's going to apply to all practitioners, physicians, NPs, PAs, everybody as of 2017. And there will be no penalties for NPs and PAs until at least 2018. But everybody's going to be subject to it going forward. They did a few things on PQRS. They did if you've heard about the fact that practitioners, hospitals, clinicians were given a little extra time to declare for a hardship exemption for meaningful use. They formalized the rules for that in the physician fee schedule. They updated the ambulance fee schedule, geographic payment areas based on the 2010 census, and our updates to the RUCA codes. So you can look for that. Something that should be good for some rural providers, they're eliminating the 10-day and 90-day global surgery payments. And what they found was that when the surgery was done, there's usually assumed number of visits, follow-up visits attached to that as part of the value, and those weren't consistently being provided. And so they're eliminating them and going to go back to a regular payment to figure out how many services are being provided. But for rural, this is kind of good because if a beneficiary has gone off to an urban location and had a surgery of some sort done, and then they come back to the hospital or the clinic for their follow-up care, if there was a global payment bill, they couldn't actually get paid for that follow-up care in that 10 or 90-day window. So by breaking this up, they will be able to, and they won't have to figure out whether a surgery was performed that way. A couple other minor things there. I'll go on to the next slide. The outpatient PPS rule was published on Monday in the Federal Register, and there are a few issues there in terms of they're going to start packaging the ambulatory procedure codes for some services. They have identified some additional codes for payment. There was some discussion about whether sole community hospitals would get to keep their rural adjustment, and they're going to allow that for now, and they're going to keep looking at that. And then there is a note there at the bottom about the overall increase for rural versus urban. It's pretty close, and it was pretty straightforward this year, so not much rural. We'll go on to the next slide. Just wanted to make you aware if you're affiliated with home health, or if your hospitals are affiliated with home health, that they did update the home health conditions of participation, at least in a proposed rule, last month. And so the comment period is open for that, and just make folks aware of that. Next slide, basic health program. Just wanted to update you on this. This is sort of, you could also call this the churn program, that for those folks who are just above the Medicaid eligibility rate for Medicaid expansion if states expanded, but they're under 200% of the federal poverty level, so they're likely to be on the marketplaces or the exchanges, and they're likely to have the highest subsidy rates. But if they lose a job, or if they add a child, or if something happens that changes their eligibility, and they expect to sort of this group to churn back and forth between Medicaid and health insurance, that to simplify the administrative burdens of all of that, they could just create this voluntary program where they take them off from the exchanges and they run this program. And so they were just updating the requirements for that. I know Minnesota was the only state for, I think, 2015 that was looking at doing this, but more are looking at it for 2016, so these rules will be relevant for those states. Next slide. I'm sure you all heard about the Office of the Inspector General report on outpatient services. If you haven't, there's a link to the report. They noted that because statutorily CAUs collect 20% of their costs rather than of the Medicare rate, that beneficiaries receiving outpatient services from critical access hospitals are generally paying more. They did also note that because most beneficiaries have a Medigap policy, that's supplemental insurance, they don't actually pay it, that second insurance does, but that can affect other rates. If the interesting part I thought was that before the outpatient PPS was adopted in 2000, everybody was paid this way. And so when they transitioned off from it for the PPS folks, it wasn't such a big deal. They've been gradually scaling it down. And so it's trying to figure out how we can do this for critical access hospitals so that beneficiaries who go there are on a par and there isn't a disadvantage for the critical access hospitals. But to do that, it's going to be an increase in Medicare payments because Medicare has to make it up because of the cost-based reimbursement issue. So, of course, the Inspector General's idea on this was, again, to suggest that CMS request permission to decertify or reclassify any critical access hospitals that came in under the necessary provider provision. Again, we would, and that's why we added that last paragraph at the bottom of this slide, is to make sure that people realize the Inspector General is not the rest of HHS, so this is not the department or the president saying that all 849 of those critical access hospitals should be decertified. Next slide, please. So there's a series of slides here about meaningful use and the updates that were made as a result of the flexibility rule. And I'm not going to go into those, but just know that basically many providers were given an extra year before they have to go into stage 2. There's still 2 years in stage 2. Stage 3 will begin in no earlier than 2017. And there's some flexibility about which technology you use and all of that. The next slide, slide 8, is an updated generic meaningful use timeline. It's not specific to calendar year or fiscal year for hospitals or providers, but just to give a sense of where that is. Some people who are visual might like that. And then the last slide is the meaningful use hardship exception extension. Say that 3 times. This is where CMS gave them until November 30th to go back in and apply for a hardship if they couldn't meet either their previous deadlines, hospitals, or practitioners based on lack of the 2014 certification. And I will note that the CCHIT, one of the EHR certifying entities, just announced that it's going out of business as of the end of this week. And so there could be some more upheaval in terms of how all these EHRs get certified. Someone quoted that there were over 3,000 EHRs and modules certified by these entities for stage 1, but a little over 300 had been certified for stage 2. So a lot of folks who were using an EHR or a module that was certified are probably scrambling to figure out what they're going to do for the next stage. So there's a lot still up in the air here. And so folks do have until November 30th to file for a hardship exemption if they qualify. And that's it. I don't know if there's time to take questions. If not, I will just, you can feel free to email me or call the office.
Looks like there's a question in the chat box. Cheryl Bischoff from Montana was wondering, back to your slide, what was meant by a value modifier when you're talking about the physician fee schedule? Got it.
Yep. So one of the other, I'm trying to remember if it was under the Affordable Care Act, but there's the physician value-based modifier, and it's on top of the physician quality reporting system. It's on top of meaningful use, but it was sort of a transitional. It's looking overall at the value. It's another attempt to move from volume to value, and so it's CMS is aligning it as much as possible, and over time even more so with the physician quality reporting system, but it's literally reporting quality measures, claims-based or registry or anything like that, but there's a set of measures that you have to meet, and if you don't, they're going to sort of rank you. Without using a star rating system, they're going to, by the performance on certain measures, they're going to either provide bonuses or penalties for not meeting performance measures on quality. CCHIT, Jill CCHIT. If you Google CCHIT, that's the company that's going out of business.
And to clarify, that's the company that's certifying the EHR vendor's
Yep.
products. They're not the vendor themselves.
Correct.
Great. Thanks so much, Aaron. We really appreciate your update.
Yep. All right. Take care.
And now I'd like to welcome John Gale to the call. John is a research associate with the Maine Rural Health Research Center at the University of Southern Maine and is a member of the Flex Monitoring Team, and he's going to provide a short update about the work of the Flex Monitoring Team. Welcome, John.
Thank you. Excuse me. I just wanted to go very briefly over some of the projects and the new activities we have. I know most of you probably heard some of this, but for those that haven't, we in the monitoring team focus on the core areas of Flex with the folks at North Carolina doing financial performance and operational performance, Minnesota taking on quality, and we're doing the community-focused activities in core area 3 and also working on a lot of the evaluation activities. So for the coming year, we have a couple of reports coming out pretty quickly, one of which will be on hospital and critical access hospital charity care policies and bad debt policies, which we think will be interesting. That should be up on our website. It's been through the office. We shared comments with John Supplett, the American Hospital Association, just to get his feedback. And that should be ready to go very shortly. We've got work going on. I've also been asked to let you know that some of the folks at North Carolina that the individual hospital financial report material is being sent or has been sent, so you should keep an eye out for that. Moving forward for the coming year, we have projects focusing not only on preparing our integrated report, where we're pulling together a variety of measures from the financial reports, quality, and community engagement and community health improvement activities of hospitals. We'll be doing individual reports. It's going through a testing and an evaluation stage, so we'll be looking for feedback from it. We'll be building on, from you on it, we'll be building on the work that North Carolina has done with financial performance. Quality and community being, I think, a little more complicated because we're pulling in different data sets. We have projects looking at population health. You may have gotten an email from Karen Pearson in my shop on getting some additional examples of population health activities for us to look at. We're really looking at it, trying to get an understanding of what hospitals are doing and how. UNC will be doing a project this year that is looking at specifically the impact of financial and operational interventions funded by the Flex program. Minnesota's doing work with quality around, and I'm looking for that in terms of measuring quality performance. So long and short of it is we have a lot going on. We have work going with looking at the EMS activities of the Flex programs and working with the office to suggest measures. Many of you may have heard of this at the last snowstorm meeting. So in a nutshell, that's where we are. I mean, we're moving forward on a lot of fronts. You can always go to the Flex monitoring website, the FMT website, if you're looking for any of our products, and certainly you always feel free, especially for those who may be new Flex coordinators, to call any of us at the 3 centers if you have questions about our work. I think that's it.
Thanks so much, John. Does anyone have any quick questions for John? All right, great. Thank you.
You're welcome.
Tracy, this is Larry Broner.
Hi, Larry.
Hi. For John.
Yes.
John, the integrated report, did I read where the market feature of that is 75% inpatient?
I guess I'm not understanding the question.
Okay. From what I understand, and there's a a proprietary model out there that uses 75% of the hospital's inpatient as a proxy for its market share. And I've always complained about that, being that our hospitals, the critical access hospitals, are probably more 75% outpatient.
Exactly.
And I was, if I read this correctly, I was very disappointed to see that the flex monitoring team is going to use the same metric.
That's coming out of North Carolina, and I would be doing my best guess at backing and filling if I tried to give you an answer on that.
Okay.
Can do. Since Mark and George Pink have been working on that, I can check with them and provide that feedback.
Appreciate it. Thanks, John.
You're welcome.
Any other questions for John? All right, thanks so much, John. We appreciate it.
Welcome.
So now we'll move into our topical presentation today. Many, if not all, of the state flex programs have, over the last few years, been working very heavily with their quality improvement organization, not only on the quality improvement activities that you had ongoing within your flex program, but also really focused work on MD-QIP program and increasing participation in that, understanding the value of participating in the MD-QIP program, and then working on reporting into it, and then transitioning and then to quality improvement measures and activities. The QIO program 2 scopes ago had rural involved with it, then they removed that from the scope of work, and now the new scope of work that the quality improvement organizations, as we knew them, were working under has really changed into kind of separating their work into 2 groups. And since many of the programs are working so closely with the quality improvement organizations in your state, we wanted to provide some clarity about what the new scopes of work look like for the quality improvement organizations into their 2 new models. And so we have 2 speakers joining us today to talk about focusing on the quality innovation network portion of the quality improvement organizations, as that is probably the most applicable to the FLEX program. So I'd like to introduce to you our 2 speakers today. Kim McCoy is the State Quality Innovation Network, or QIN-QIO Program Director with Stratus Health here in Minnesota. She leads Minnesota's initiative to improve healthcare quality and patient safety for Medicare beneficiaries throughout the state. She manages efforts to address chronic disease, improve coordination of care, prevent healthcare-acquired conditions, and increase the value of healthcare. And she also works with rural communities to facilitate collaborative health assessments and planning, and to foster community-driven health improvement. Joining her is Gayla Middlesteed, and she is the State Program Director with TMF Health Quality Institute. She has an extensive nursing career in hospital managed care and in the physician office setting. She's a Team Steps Master Trainer and brings years of clinical experience, strong quality improvement background, combined with knowledge of team development, including the provision of training and technical assistance to healthcare providers about quality measurement, data management, and reporting with all phases of quality improvement endeavors. She's worked with both acute care and critical access hospitals, and they both are really experts in kind of leading the charge within the QIN scope throughout the country about the work that's developing as these networks get established. So with that, I'd like to welcome our speakers to the call and turn the content over to them.
Great. Thank you very much. This is Kim McCoy from Minnesota, and we really appreciate the invitation to be with you today and to share the work that we are really just getting started with. The contract for this work began in August, so we're really just at the front end of this new contract. And so what I'm going to be doing today is I'm going to give you really kind of a broad brush of what this new QIN-QIO structure looks like, what the focus areas are of the work that we're going to be doing, and then talk a little bit about how we in Minnesota, and Gayla will talk a little bit about the work that she's doing in Oklahoma and with TMF, but how we're working together with our FLEX programs and how we can really use sort of leverage the opportunities that are available to strengthen collaboration between our organizations to improve healthcare quality and safety in rural areas. So I thought I'd start just by giving you a little bit of background about Stratus Health. We're an independent nonprofit organization. We lead collaboration and innovation in healthcare quality and safety. We primarily work across Minnesota, though we do have some initiatives that we're working on across the country. We've been doing this work for over 40 years. Primarily, well, we got started as the Quality Improvement Organization for Minnesota, but have since expanded into a variety of other areas. You can see here our strategic kind of focus areas, our health information technology, rural health, health equity, and long-term and post-acute care. We work with providers really across the spectrum of care, so in a variety of settings, hospitals, home health, nursing homes, clinics, hospice providers. So, you know, we really kind of work with anybody who interacts with the healthcare system, with Medicare beneficiaries, and we really try to approach this improvement work that we're doing as kind of a systematic, collaborative, community-driven approach to quality and safety. So the QIO program, the Quality Improvement Organization program, has been around for a little over 40 years, as I mentioned. And just recently, with this new contract that began in August, we saw some pretty significant changes to the program, and there's been conversation about these changes over the past several years at least, if not, you know, even longer. Some of them have been sort of in consideration for probably about a decade. But this is when we really saw the sort of the implementation of a lot of these changes that have been talked about. So one of the biggest changes that we saw this year is the separation of kind of the two main buckets of work that quality improvement organizations have done in the past. So we've typically had two functions. So one, the beneficiary and family-centered care work, which is really the case review work that we've done. So we in the past have had a group of folks here who have handled those case reviews, grievances that have come through Medicare beneficiaries or their families, and it's been our role to investigate those grievances and then put into place improvement plans and work with them to really make improvement within their facilities. That work has been now completely separated from the collaborative quality improvement role of the QIOs. So Medicare essentially split the country into regions and identified organizations to handle that case review work on a regional basis. So depending on where you are in the country, you might have a different BFCC QIO who's handling that work for your state. In the case of Minnesota, for instance, it's KIPRO, which is based in Ohio. They're handling the case review work for our 10-state region. One organization was not allowed to serve as both the case review QIO and the QIN quality improvement QIO, so that work has now completely been separated and is being done by different organizations. Another big change that we saw with this new contract is a shift from a 3-year to a 5-year program cycle. So in the past, our contracts for the QIO work have been for 3 years. This is the first one that's been extended to 5 years. And we think this is a good thing. We're excited about the opportunity to really be able to to foster some increased sustainability when it comes to the quality improvement work that we're doing, to have a little more time to really see the impact and maximize the results of the work that we're doing. So this will just give us, kind of a little more time to work with organizations in our region and to really make some significant improvement and demonstrate that improvement through measurement and evaluation over that time period. The other really significant change that came about in this with this contract is the shift from a fairly state-based approach in the past to more of a regional approach to this quality improvement work. So depending on your state, may have had a quality improvement organization that was specific to your state. So in the case of Minnesota, Stratus Health served as the quality improvement organization for Minnesota, and that was the case for many states. They, those QIOs were state-based. With this contract, the way that Medicare requested proposals for this contract, they required proposing organizations to apply for the work with a minimum of 3 states and a maximum of 6 states. And they left it completely open to the organizations themselves to determine what that state combination would look like. So in other words, they didn't select any regions themselves. They didn't predetermine what any of those state partnerships would be. They just said, when you submit your application, make sure that you're doing it with at least 3 states and up to 6. So you can imagine they got a variety of applications. In some cases, they got multiple applications for the same states. They really allowed themselves a lot of flexibility to determine what that final arrangement would look like. And I'll show you a map of the kind of what the end result looked like in just a minute. The other thing that they set up is this new contract structure. And each organization that was awarded a QIO contract is operating under what they call an IDIQ contract. So that stands for indefinite delivery and indefinite quantity, which is completely, totally ambiguous. But essentially what it does is it allows the organizations to operate in such a way that CMS can then continue to issue requests for proposals or funding announcements to organizations that already have these IDIQ contracts in place. So it sort of gives them a little more flexibility to award contracts to these organizations kind of over the course of this next 5-year period. So we sort of anticipate that as we go, more contracts for different kinds of work will be released. So it's a different kind of contracting vehicle than we're used to. The initial sort of task order or scope of work that we received under this IDIQ contract is the core QIO work that I'm going to talk about over the course of the next half hour or so. So these new Quality Innovation Network QIO contracts were awarded in July of 2014. Most of the work started August 1st. As opposed to some of the state-based QIOs that I talked about before, there are 14 of these QIN-QIOs that are now providing this QIO support across the country. So they serve 50 states and 3 territories. We'll talk a little bit about sort of the variety of legal and structural arrangements within these QIN-QIOs, just to give you a sense of how these QIOs are set up in different ways across the country. And, from your perspective, that structure may or may not have an impact on the work that you're doing with QIOs. from our perspective, it certainly makes a difference in terms of how we interact. But just to give you an example, Stratus Health is working in partnership with Wisconsin and Michigan. The three of us, Minnesota, Wisconsin, and Michigan, came together to form the Lake Superior Quality Innovation Network. So Lake Superior Quality Innovation Network is not a legal entity. We each still have our state-based organizations. Stratus Health still exists in Minnesota, Metastar is in Wisconsin, and MPRO is in Michigan. But we've agreed that we're all going to work together in an equal partnership to do the work of this QIO arrangement. So Minnesota is serving as the prime contractor for the Lake Superior QIN. Wisconsin and Michigan are then serving as subcontractors to Stratus Health. But as I mentioned, we've agreed that we're doing this work in partnership. And I'm going to, at this point, allow Kayla Middlestead, who's working with the TMF Health Quality Institute, to talk a little bit about how things are structured for their particular QIO and to give some background on the arrangement that they have. So, Kayla?
Hello, everyone. Sorry, it was taking me a little bit to figure out how to unmute my phone. As you know, this is a big change for everybody. We're all kind of learning how we're going to do this work. It's a pretty tall order. For Texas, a lot of our work is going to be done through building some long-term partnering relationships and through learning in action networks. We also are going to have networks. If you go to our website, there are some, we want you to create an account, go into there, and there's all kinds of networks from readmissions to health-associated infections, and please join those. What that will do is, then on a weekly basis or however you want to designate, that will give you an opportunity to learn what is up and coming or current in the news on any of those topics. It will also allow you to be aware of any webinars and educational efforts that we are doing within the states that we're involved in, which would be Oklahoma, Texas, Arkansas, Missouri, and Puerto Rico. Those webinars are free. We encourage you and any of your facilities to join those. There's also a wealth of tools and resources that you can access through this as well. So for in our state, a lot of our effort is going to be done through
Oh, did we lose Kayla?
Kayla, it's star 2 to unmute your line.
Kayla, are you there?
Yes, can you hear me?
Now we can, yep.
All right. I apologize for that. A lot of ours are going to be through virtual meetings and virtual contact. It will no longer be the face-to-face of which many of you have been accustomed to, and this is to work smarter, wiser, and to be more cost-effective in the efforts that we do. And Kim, I'm going to hand it over back to you.
Great. Thanks, Kayla. So we're going to talk in just a minute about the focus areas of the QIO work so you can get a sense of the different topic areas and settings of care that we're going to be working with and how all of that relates to the work that you're doing in rural areas and with critical access hospitals. I just wanted to give you a quick look at how the QIN-QIOs are laid out across the country. So this gives you a picture of the way that Medicare awarded these contracts this time. So I mentioned there were 14 QIN-QIOs. You can see that there wasn't a requirement for these QIN-QIOs to be geographically contiguous in any way. So for instance, California, Arizona, Florida, and Ohio make up one QIN, the Health Services Advisory Group. You can also see that Pennsylvania, West Virginia, New Jersey, Delaware, and Louisiana make up the Quality Insights QIN. So there's quite a bit of variability in the kind of the reach and the organization of these QIN-QIOs. And if you're not familiar with who your QIN is yet, you'll see I provided a link later in the slides to a QIN-QIO directory, so you can actually go to that page and see who your QIN is and find the contact information there. But I just wanted to give you a sense of what the structure looks like in this new arrangement. Okay, so now I'll talk a little bit more about the work of the QIN-QIO program. And I should have said at the beginning too, if you have questions as I go along, please feel free to type your questions into the chat box. And certainly at the end of the presentation, we'll have an opportunity to have some conversation about this as well. So QIN-QIOs are responsible for working with providers and communities on quality initiatives to improve patient safety and clinical care at local and regional levels. And we're doing this work, as I mentioned, in a variety of settings, on a variety of topics, and the work looks a little bit different from region to region, from QIN to QIN. We have a set of evaluation measures that we're all responsible for. We have a certain set of activities that Medicare has laid out for us. Gayla mentioned earlier kind of some of these key roles of the QIN-QIOs that permeate the full scope of work that we're all doing. And Gayla, maybe I'll just let you jump in here and say a little bit more about the kind of the key roles of the QIO as you've described them here. Are you there, Gayla? Okay, maybe I'll just I'll just jump in. So you can see here these are kind of the roles of the QIOs that span all of the topic areas that I'm going to talk about in a minute. So really what the QIOs are tasked with doing is to champion quality improvement and data-driven change at the local level, working with patients, with families, with caregivers, with providers, and other partners across the spectrum of care. Facilitating learning and action networks. So these learning and action networks are a component of each task within the contract. So the idea is that we're working at the community level with individual organizations and providers, but then we're using these learning and action networks to provide information and education to communities of providers across the entire state in a very broad, far-reaching sort of network of learning. So this is the idea of kind of spreading what we know and what's working to folks throughout our state, and in fact now in this new arrangement throughout our region. Each QIO also really serves as an advisor, as a coach, as a technical expert on how to use quality improvement tools and resources to implement the work that we've been tasked with doing, and then finally to communicate effectively with really anyone who is impacted by this work or has a role in the work and the change that we're promoting throughout this contract. So really providing opportunities for optimal learning to create that behavior change on the part of providers, patients, families, caregivers, and other support organizations as we work over the course of this next 5 years. So there are 4 focus areas within the QIN-QIO contract. The first is very prevention focused. It's focused on treatment and management of chronic disease. The focus areas, or the topic areas, the task orders within this focus area include cardiac health and reducing cardiac healthcare disparities. This is looking at particularly activities around what they call the ABCSs, so aspirin use, blood pressure control, cholesterol control, and smoking cessation. Work around reducing disparities in diabetes care, so this is primarily through diabetes self-management education programs, by engaging community health workers, increasing availability of certified diabetes educators, but really looking at targeted efforts to reduce those disparities in diabetes care and increase the use of diabetes self-management programs. And then finally, within this focus area is the task that's focused on improving prevention coordination through HIT. So this is really about helping organizations meet those meaningful use requirements and using HIT as effectively as possible to improve prevention. Focus area number 2, which is called Better Healthcare for Communities, is all about improving patient safety with a significant focus on healthcare-acquired conditions. So reducing healthcare-associated infections in hospitals. Primarily here we're talking about catheter-associated urinary tract infections, central line-associated blood infections, what else? Clostridium difficile. So working with hospitals to address those infections in particular, working with nursing homes to reduce those healthcare-acquired conditions, with focus also on reducing use of antipsychotics in dementia patients. And then the final component of this focus area is improving care coordination and reducing adverse drug events. And that is community-based work, so bringing providers from multiple settings together to really kind of tackle care transitions, reduce readmissions, and reduce avoidable admissions as a community. So the focus of this work is really kind of bringing those hospitals, clinics, nursing homes, as well as long-term support service organizations. So folks like Meals on Wheels and aging services and transportation providers, getting all those folks around the same table to tackle this care coordination and communication initiative together. So to really set community level goals and make progress as a group. Focus area number 3 is better care at lower cost. So this is about working with both physicians and hospitals to increase the value of the work that they're doing. This is a lot about looking at those quality measures and quality reporting, and working with, in particular, the hospital focus here is on working with both inpatient and outpatient settings, as well as ambulatory surgery centers, inpatient psych facilities, and critical access hospitals to improve that overall quality of care. And then finally, the final focus area of this work goes back to that BFCC, the case review work that I talked about earlier. So, even though the case review QIO, the BFCC QIO work has been separated from the QIN-QIO work, we're still working in partnership. So those case reviews that are done, when they generate opportunities for improvement, the need for improvement plans, that work will then be referred to the QIN-QIOs to work with those organizations to put those improvement plans, those improvement activities into place. So that work really depends on sort of how the case review happens and the types of referrals that we get from that work. So I wanted to pull out a few things that were specifically relevant to rural communities, and Nicole or Tracy, I think, mentioned earlier that rural had a prominent place in the 9th scope of work. So 2 scopes of work ago, in the most recent, the previous scope of work, it was a little more subtle, I guess we could say, within that contract. And here it's sort of a mix. Like, it's come back, but I would say in a maybe not as prescriptive way or a specific way as it was in the 9th scope of work. So a lot of the work that that is specifically relevant to rural areas or to critical access hospitals is often listed as kind of an optional component within this work. And so while I think a lot of us in the QIO world recognize the importance of working with rural communities and with critical access hospitals, the contract does allow for some flexibility as to how that happens. So there's an option to work with critical access hospitals on that meaningful use task that I talked about, so to improve the EHR adoption, workflow processes, reporting of clinical quality measures, and other meaningful use to support practice transformation. There's an option to work with critical access hospitals to improve clinical outcomes with respect to the cardiac health and diabetes work that I talked about. With respect to the care coordination work, so I talked about that community-based work to really look at care transitions, reduce readmissions. Within that coordination of care communities, at a minimum of 10% of the beneficiaries who are included in those communities must reside in rural areas. And just to give you a sense of what that 10% means, the requirement for those coordination of care communities is that we reach 60% of the Medicare fee-for-service beneficiaries in our region. So in the case of Minnesota, if we look at the fee-for-service beneficiaries who are in our state, 60% is about 250,000 Medicare beneficiaries. So as we establish those coordination of care communities, we're going to be looking to establish communities that help us reach 250,000 beneficiaries. 10% of those beneficiaries, so about 25,000, need to be residing in rural areas. So, absolutely, we'll be looking at establishing those coordination of care communities in rural areas within our state. There's also some language in the contract about special innovation projects that address quality and value in rural areas. So, in the past, these special innovation projects have come about over the course of our QIO contract. So, the CMS would kind of put out requests for proposals periodically in that 3-year and now in the 5-year period to say, we're interested in hearing about ideas, innovative ideas that you have to address particular quality improvement initiatives. And so what they've said in this contract is that they're interested in special innovation projects that address quality and value in rural areas. So we're anticipating that at some point we're going to have the opportunity to propose innovative projects that we could do to address rural needs in particular. And then finally, to improve the performance of quality, patient experience of care, cost and efficiency, and outcome measures related to value-based payment and quality reporting. So again, this is one of those where critical access hospitals in particular are mentioned in terms of improving inpatient and outpatient measures. The kind of caveat with this one is that Medicare is anticipating that they're going to make some adjustments to this particular task. So that one is sort of on hold at the moment while we're waiting to hear from Medicare about kind of what that task and the scope of work for that task is going to look like as we go forward. The overall approach for this work, so if trying to get a sense for kind of why Medicare took this approach to restructuring the QIO program, to this regional approach, to the extended period of time, to this new contracting mechanism. And there are a variety of ways to kind of think about it, but the way we see it is that this is really an opportunity to leverage the strengths of the partners to maximize our impact and our efficiency. So, you know, we like to think that by, you know, in Minnesota, by working in partnership with Wisconsin and Michigan, we're really going to be able to tap into the strengths of each of our 3 states so that we can make a greater impact together than either any one of us might have been able to do alone. Now, what I also like about this approach is that there is some flexibility for us to be able to address the particular needs and environments within our states. So it's not so prescriptive that it limits us, but it's just prescriptive enough to kind of provide some structure, but also allow us to work within our own, to address kind of our own needs and tailor this to our own environments. They're really looking to each of these QIN-QIOs to integrate work across those focus areas. So all of those topic areas and tasks that I just talked about are meant to be fairly integrated. So, you know, those coordination of care communities that we talked about, we're hoping that they're also going to be working on improving cardiac health and reducing those diabetes disparities. So they aren't meant to be completely separate tasks, but rather to you know, take a really holistic kind of comprehensive approach to improving quality and safety. There's a huge focus this time on fostering community ownership and sustainability. So as we go in and work with and engage with providers and partners and communities, the idea is that, you know, this is about sort of, as the saying goes, teaching folks to fish. So, you know, the idea is that we're gonna get this work started, but we're going to do it in a way that we can hand it off to the communities, the organizations, the patients and families themselves to really take this and run with it in the long term, so that it is a sustainable, ongoing effort. And then, you know, as I mentioned, that, you know, especially with the coordination of care work, this is meant to be a very broad, far-reaching effort. So, you know, they're really looking at us to touch a large percentage of the Medicare beneficiaries in our regions. I listed Minnesota in here, but at a national level, this is really meant to impact a really significant number of the Medicare beneficiaries in the country. So they're really going to be looking to us to demonstrate that far-reaching impact. So what are some of the things, some of the implications for you and for others who are going to be looking to engage with the QIN-QIO organizations? So as I mentioned, there's a rural emphasis. You know, there's reference to rural communities and critical access hospitals throughout this contract. Much of the kind of the emphasis on rural communities is not super prescriptive, so there's flexibility, which means, you know, that this work is probably going to look different from state to state or region to region. The other caveat I put here is that the evaluation itself may drive more of a suburban-urban focus. So again, if we go back to that coordination of care example, where we need to be impacting 60% of the Medicare fee-for-service beneficiaries in the state, what that means for us is that we really need at the outset or the initial start of this work to make an impact in the urban areas. So, you know, the vast majority of our Medicare beneficiaries are based in the Minnesota case in the Twin Cities metropolitan area. So in order for us to meet those evaluation requirements of the contract, it's going to be essential for us to have communities based in that metro area. Now, there's still that 10% requirement for rural areas, so we absolutely will have rural communities as well, but we're not going to be able to meet that evaluation measure without metro-based communities. Even though we're structured in this new regional way, the evaluation of our work is still based at the state level. So each state will be submitting its own performance report, and the evaluation that's done by Medicare will be at that state level, not at the regional level. And I say that just so that you have a sense when you're working with the QIN-QIOs of how they're going to be evaluating their performance and sort of what their mindset is going to be as they're working with partners. There's going to be an increased emphasis on partnerships with non-clinical entities. So while much of this work is going to be done in partnership with some of the more traditional providers, hospitals, primary care practices, nursing homes, Medicare has also said you really need to start to engage with those other types of support organizations. So like I mentioned earlier, the folks who provide support with meals or with transportation or with household chores and those other activities that are really important for folks who are dealing with transitions in their health, dealing with healthcare issues. We've got this 5-year time frame, which we hope will give us kind of make us better able to really instill that community ownership and sustainability. And then, as I mentioned, there's enough flexibility in the contract to really allow for tailored approaches across the country. So another change that we've heard a lot about from hospitals is that the QIN-QIOs are no longer able to provide that technical assistance with hospital reporting. And so essentially our hands are tied when it comes to this one. What we've been told by Medicare is that when we hear from hospitals who are looking for technical assistance with reporting, that we need to refer those hospitals to these other resources that are available. So I listed the phone numbers and the links with the Q&As here. I'm guessing many of you who are working with critical access hospitals have heard about this and know about these resources, and you probably could say a lot more about it than I have here. I'm just keeping it brief. But this is the state of things for us, and it's we've definitely heard some frustration from hospitals, and I can tell you it's hard for us too to kind of have to say, you know what, we're sorry, we can't do this same work that we've been doing in the past, and this is kind of the new way of doing things. So we're doing our best to try and help where we can when it comes to the hospital reporting. So in the last few minutes, I just wanted to give you some examples of how we at Stratus Health are working in partnership with our FLEX program here in Minnesota. And I think I saw that Judy Berg from the Minnesota FLEX program is on the line, so I invited her to jump in if she has anything else to add as we go through this. But so we have a small contract with the Minnesota Department of Health to support some of the rural Minnesota needs and priorities. And the 3 focus areas that we've kind of built into that contract are support with MB-QIP, building quality improvement capacity and skills, and working with rural hospitals on community health needs assessment and improvement. So with respect to MB-QIP, the way that we set up this work is that Stratus Health would work with critical access hospitals on increasing measurement capability through MB-QIP and then our own Minnesota quality reporting system. So working with critical access hospitals, we would identify a particular MB-QIP measure, and in our last contract, the measure that we worked on was the HCAHPS medication communication measure. We would work with those hospitals to set specific goals for improvement. We'd look for opportunities to improve the validity and reliability of the measures that are submitted, and then we'd provide technical assistance for the data submission requirements. And in this case, that was for the ED transfer communication and the CPOE measures for phase 3 of MB-QIP. We also worked on building quality improvement capacity, and in this our most recent contract, the way that we did this was by offering opportunities for critical access hospital staff to participate in the IHI open school curriculum. So IHI, in case you're not familiar, is the Institute for Healthcare Improvement. They have an established program for achieving a quality improvement certificate. And so what we did was we invited critical access hospital staff to participate in that open school curriculum. We made that available to them at no charge, and then we provided some networking opportunities over the course of their participation in that curriculum so that they could network together to share what they were learning, to talk about the relevance to their particular organizations and how it worked, and then to also earn continuing education as part of that work. And then the last thing that we did in partnership with our FLEX program was to work with 8 communities. So this was rural hospitals working in partnership with their local health departments to facilitate a more collaborative approach to community health assessment. So essentially what we did was we put out an offer to all the critical access hospitals in our state and said, if you want some assistance with your community health assessment process, we'll provide some assistance to you. And for the most part, that was in the form of facilitation. So we would work with, like I said, the hospital and the local health department to convene community partners and really work through a collaborative community health assessment process. We provided some assistance with data analysis and then really tried to foster a community-driven approach to health improvement. So when it comes to opportunities for you all to be collaborating with your QIOs, I just wanted to offer sort of a few things to keep in mind. So, you know, we need to be really careful about not duplicating effort that's already sort of paid for by Medicare in the QIO work. So, you know, in the case of the work that we've been doing with our FLEX program, we really look for things that can support and complement the focus areas that are in the QIO contract. We're also really looking for any opportunities to strengthen rural capacity to measure performance and make improvement. We try, as we're doing this work, to bring to light policy and practice challenges related to, in particular, rural needs and rural capacity and the QIO work, so that, you know, as we move forward, we can think about other innovative ways to address rural needs and rural challenges, and to so that we can really bring that information back to CMS, back to Medicare, to say, you know, we have an opportunity on a regular basis to outline for CMS what our challenges and barriers are. And so if we can hear that from you, we can share that with them and say, you know, if you could really think about other ways to do this, that would be helpful. And then I mentioned that Medicare is interested in hearing about those innovative approaches to improving quality and safety. So those are other ways that, you know, we can sort of think about working with our FLEX programs to say, you know, what can we offer? What can we propose to CMS to kind of help better target rural needs in rural areas? You know, if you're not working with your QIO already, there isn't necessarily sort of a standard approach to how that happens. I would say just, you know, reach out to them. Start, if you know somebody who's a staff at your QIO, reach out to that person just to kind of initiate that conversation about how to work together. If you don't know anybody in particular at your QIN-QIO, there is a directory online that you can access that'll provide you with the contact information. You could also check in with me if I know anybody in your particular state. I would certainly be happy to make that connection for you, and I'm sure Gayla would too. look for ways to align with other initiatives that are happening in your state or your region. Certainly what we hear a lot from the providers that we're engaging is that this work can be really overwhelming. There's so many things going on. There's so many things to think about. So to the extent that we can align this work and make it line up really well with things that they're already doing, that's really helpful. And then, be ready when you contact your QIO to talk about innovative approaches, to talk about things that you can do together that that will kind of lead to new ways of doing things and lead to other opportunities. So I'm going to stop there, and that, I think, leaves us a little bit of time for some discussion and questions. And I just want to thank you again for the opportunity to share this work that we're doing. Like I said, we're just getting started, so we've got about 5 years to be doing this work, and I really appreciate the opportunity to work in partnership with our Flex staff here in Minnesota, and so I'm sure that the QIOs, the QIN-QIOs in your states would appreciate hearing from you about how to make that happen in your area as well. So I'll stop there.
Thanks so much, Kim. So I'd like to open up the call for questions that you might have for Kim that she can answer now or maybe get back to us later on about. So if you have a question, it's *2 to unmute your line, or if you prefer, you can type your question in the chat box and we can answer questions that way as well. So please go ahead if you have a question for Kim. Well, I'll start. I have one actually, Kim. You had mentioned earlier about how the work right now is on hold for the QINs to work on critical access hospital improvement on inpatient or outpatient measures.
Yep.
So I'm curious about how that's impacting the current work that's happening at the state level on MB-QIP.
Well, and I might ask Judy to chime in on that too if she's still on. I'll tell you just kind of how conversations are happening here in Minnesota, and I would just say that it's pretty up in the air. I mean, I think what's been hard for us, as I mentioned earlier, both with MB-QIP and the QIO work, is to be able to structure that work in a way that we're being complementary, that we're providing value to the critical access hospital. So we want to make sure that we're not overwhelming folks, that we're asking to do things that are relevant and meaningful. It's. I mean, what I can say, and I could probably ask Carla Wang, who does a lot of our rural work, to comment on this further. She could share more information about it, but it's really up in the air right now because we just don't know. We don't know where Medicare is headed, to be totally honest with that task. The impression that we've gotten is that, I think some parts of this contract came together pretty quickly, and as Medicare started to hear back from the QIOs about sort of making that work practical and real, and doing the measurement, that the way they laid out some of that work maybe wasn't going to be as straightforward and meaningful as they intended. So I think they're kind of going back to the drawing board on that one so that they can kind of reframe it and take a different approach, so that we can make it more, so that it can be more realistic and achievable and doable by the QIOs.
Okay.
So I don't know if there's anybody else on the, maybe there's somebody else on the call who's had more experience with that. Maybe you've had conversations with the QIOs in your states. I'd be curious to hear from others.
Anyone have anything to add to that? I have a different question for you as well,
Yeah.
Kim. You had mentioned about how the QIN-QIOs are no longer able to provide technical assistance with reporting with inpatient or outpatient, that there's some CMS designated entities to do that. And you provided us the contact information for that, so thanks for doing that. I do have a question though. Who's supporting the CART tool? Because I know a lot of our CHs are using CART to participate in MBQuip.
Well, so my understanding is that all of the hospital reporting is being handled through those resources. That, and again, I'm not really in the weeds of that work as much. I kind of see it more from from a higher level. So again, I would be, if others have heard other things or had other experience with that, I'd certainly be interested to hear it. But my understanding is that the QIN-QIOs are not able to provide assistance with any of that reporting.
Okay. And what we can do for folks on the call is we can look into the answer to that question and just provide that specific information when we send out the recording information, because I think that's something that you'll likely hear from your CHs if you haven't already.
Yep. Absolutely.
See, some people are typing in the chat boxes. Any questions at all for Kim on the line?
Okay.
And Caleb in Colorado has offered to send something about the CART tool, so that would be excellent. And Jill's mentioned
great.
too.
Perfect. Good. Thanks, Caleb. Oh, that's a good idea. Stephanie suggested a webinar.
Okay. We will see if we can organize something with the federal office as we continue to work on MBQuip projects with them. So we'll take note of that, and I think we actually have a call tomorrow, I believe, with the federal office about MBQuip. So good timing. Thanks for the suggestion, Stephanie.
Well, so maybe I could ask a question. I talked about this QIO work at a pretty high level, but is there anything that jumped out at you as I kind of provided the overview of the different tasks, those different buckets of work that is maybe particularly relevant or particularly challenging for rural communities or for the folks who you're working with?
One of the things we've been talking a lot here at the center about lately is population health and the impact about critical access hospitals at that, and care coordination being a piece of it. So I think the role that the QINs are playing with improving care coordination, kind of under your second focus area, and bringing together the different entities in the states and in the regions to work on that is really, really exciting work, and aligns a lot with us. It's certainly a challenge for the CHs if they haven't established kind of thorough community partnerships throughout their service area. In the past, maybe they have one or two strong connections to the community, but maybe not all of them are viewing different roles in that care model right now. So that's a challenge, I think, for our program.
And maybe I'll just say, just to kind of give folks a sense of the support that they might get from the QIO in that area, because that is actually somewhat of a continuation of work that we were doing in the previous contract. And at least the way that we did that work in Minnesota, we targeted 3 communities in the state. And as the QIO, Stratus Health, what we did was we served really as the convener and the facilitator of those conversations. So we reached out to those different provider groups and partners in those communities. So just to give an example, we did one in Brainerd, Minnesota. And we brought together the hospital, the nursing homes, the home health agencies, the hospice providers, primary care clinics, and we could serve as kind of a neutral facilitator in that setting. So we brought those folks together and really worked with them to say, okay, when you look at sort of how care transitions happen and how care coordination happens in your community, where are the barriers? What are the biggest challenges? What are the things that make it most difficult for patients to really have a smooth transition? And then we worked with them together to set shared goals to determine how they would measure